So, a very good evening, everyone. So, in this particular section, I'll be discussing the obstructive lung diseases, and mainly I'll be taking up the discussion of this very important topic, that is the bronchial asthma. So, this is an obstructive lung diseases, right? And what are the other examples of the obstructive lung disease? First is the asthma. The next important condition, which is obstructive lung disease, is bronchiectasis, then bronchitis. Next, we have cystic fibrosis, and then COPD. So these are the examples of the obstructive lung diseases, right? And what is one important parameter, or what is that parameter which will decide the lung disorders as the obstructive lung disease from the restrictive lung diseases? So one important point of the difference between these two is the FEV1 by FVC. In case of obstructive lung diseases, it will be less than 70%, right, which is reduced. Whereas in case of restrictive lung diseases, the FEV1 by FVC will be more than or equal to 70%. So this is one parameter which will decide whether the given lung disease, is it an obstructive lung disease or is it the restrictive lung disease, right? Then, now let me take up the detailed discussion of the asthma. The important differentiating point between the asthma and COPD is the reversibility. COPD is irreversible disorder and asthma, it is a reversible disorder, right? So for that, we do the reversibility testing also. To differentiate COPD from asthma, we do what is called reversibility testing, where we give a short-acting bronchodilator, that is salbutamol, right? So basically what we will do first, we will do the baseline FEV1 in both the given patients. One patient is like asthma and one patient is having COPD, and we check the baseline FEV1, right? Now, after checking the baseline FEV1, then to these two patients, right, patient 1 and patient 2, we give the salbutamol nebulization. After giving salbutamol nebulization, we will wait for 10 to 15 minutes. And again, we will check FEV1, right? Again, we will check FEV1, right? Now, if that particular FEV1 is increased more than 12%, then this patient is considered as bronchial asthma. If that FEV1, which is increased, if it is less than 12%, we consider it as irreversible and we consider it as the COPD patient. So reversibility testing is the one important test which will decide whether the given patient is having COPD or the bronchial asthma. Okay, so the bronchial asthma, it's a reversible disorder and it is an episodic airway obstruction, right? And this airway obstruction is mainly because of the hyperresponsiveness and as well as the airway inflammation, right? And most of the time, the bronchial asthma, it is a reversible disorder. Very occasionally, in long-standing cases, in severe forms, it may become irreversible. Because in long-standing cases, what the individual can have is a very severe form of smooth muscle hypertrophy, right? And that makes the individual to have the irreversible nature. But majority of the times, most of the times, the bronchial asthma, it is a reversible airway obstruction. And that reversibility is by what? Reversibility is by the medications. That is your bronchodilators, right? When it becomes irreversible, when there is significant structural changes, then it becomes irreversible, right? Then followed by that, if you take the airway inflammation, just 1 minute. Just 1 second. Okay, so if you take the airway inflammation, the important cells which are involved in the pathogenesis of asthma, it is the eosinophils, right? Eosinophils, they play a significant role in the development of this bronchial asthma. What do? They release the inflammatory mediators, and that plays an important role for bronchoconstriction, smooth muscle hypertrophy, and as well as the infiltration of the other inflammatory cells also. Now, apart from the neutrophils, what are the other cells that they play an important role is the neutrophils, right? So apart from the eosinophils, even the neutrophils, they also play an important role. So what will be the classical presentation of these patients? Wheeze. Wheeze is the classical presentation of these patients, right? And even on auscultation, you will have the wheeze. On auscultation, mainly you will have the expiratory wheeze. Right? You will have the expiratory wheeze, right? Only in case of very severe form of asthma, right, you will have both inspiratory and expiratory wheeze. But there is one form of asthma called status asthmaticus where the chest may be silent also. Why do you think that the chest is silent? Because the bronchoconstriction is so severe that air is not passing through. That is the reason why the airway, whenever you auscultate, the chest may be silent as well, right? So shortness of breath, then the cough, and then mucus production. So these are all the clinical manifestations that you'll have in patients with the bronchial asthma, right? And these patients with the bronchial asthma, where they have cough with expectoration, the expectoration contains some important particles or some important structures. And these are called as the Kirschmann spirals, right? Kirschmann spirals. Then in the mucus, you can have the presence of the Crayola bodies, and there can also be presence of the Charcot-Leyden crystals. Right, Charcot-Leyden crystals. Okay, so these are the three important C's that you need to remember in the sputum of the patient with the bronchial asthma, right? And next is there are some factors which will cause exacerbation of the bronchial asthma. And once there is an exacerbation, these patients will be requiring hospitalization, without which the individual may go into death of the individual. Okay, and what is the important factor for the exacerbation? It is the infection, right? So any respiratory infection that will be trigger for the development of the acute bronchospasm, where they will be requiring immediate hospital admission. And once there is exacerbation, the drug of choice will be short-acting beta agonist. Salbutamol is a drug of choice, without which the individual can go into a state of death also, right? And apart from short-acting beta agonist during the exacerbation, these patients, this short-acting beta agonist should be given in the form of the inhalation or like nebulization, right? Along with that, these patients have to be given steroids also. That is, IV hydrocortisone is what you need to give. So basically what the steroids will do, steroids will potentiate the effect of these beta-2 agonists. That is the reason why you need to give steroids. And if you take the prevalence, it is more in boys than compared to that of girls, right? And even the ratio is around 2:1. Okay, so during the childhood, it is more common in boys than girls. Then what are the risk factors for the development of the asthma, right? Or what are the things the individual should avoid? The very important risk factor is smoking, right? Smoking is a very important risk factor. Apart from that, you have many other risk factors like allergens are there, right? Air pollution is another important risk factor. Infection is a risk factor that can cause acute bronchospasm also, right? And even the diet and high intensity exercise. So these are all the risk factors, right? Allergen, air pollution, infections, right? The smoking, obesity, diet. So this diet, if you take, okay, so after the diet, the individual can have an attack of asthma, and that we call it as, this is mainly due to GERD, right? And this is called as the gastric variant of asthma. And what is the treatment that you need to give in case of gastric variant of asthma is that you should not give short-acting beta agonist. You need to give proton pump inhibitors mainly to reduce the GERD component. Okay, that is gastric variant of asthma, right? Next. Then coming to the pathophysiology, as I have said you, it is airway hyperresponsiveness. The other thing is smooth muscle hypertrophy, muscles mucus secretion, and then airway thickening. Right, so airway hyperresponsiveness, smooth muscle hypertrophy, mucus secretion, and then the airway thickening. Now, if you take this mucus secretion, right, so if you take this mucus secretion, So what does the mucus contain? This particular mucus, it contains three important C's I said you, right? Charcoal-laden crystals, Cashman spirals, and then Crayola bodies. These are the three C's that you have in patients with the asthma in the sputum, right? Then followed by that, what are the structural changes that you'll have in the airway in patients with the bronchial asthma? The structural changes that there will be is the smooth muscle hypertrophy. And the smooth muscle hypertrophy is what is responsible for narrowing of the airways. And because of which there is an obstruction during expiration, and that will result in the development of V's, right? And next is subepithelial collagen deposition and as well as the neutrophil proliferation. So these are the structural changes that will happen within the airway. And even vascular changes also happen within the airway, and that is angiogenesis and the vascular proliferation, right? Angiogenesis and vascular proliferation. They also contribute to the development of the airway edema. They also contribute to the development of the airway edema, right? And what are the triggers now in order to have an exacerbation? That is allergens, irritants, infections, exercise, exposure to cold air, and drugs. Drugs, we call it as drug-induced asthma. And which particular drugs are those? Number one, non-selective beta blockers, right? Non-selective beta blockers. And another important group of drugs are the NSAIDs. And among the NSAIDs, it is mainly the aspirin. So this is your drug-induced asthma. Next is the occupational exposure, right? So whenever during the occupation, like if the individual is exposed to dust or the individual is exposed to some irritant odors, and if the individual is exposed to a smoke, that will be a trigger. So these are the triggers. Then, okay. So having said about the risk factors, pathogenesis, and as well as the triggers, let me tell you, how do you diagnose? Diagnosis is very simple. That is by history and physical examination. And very important is pulmonary function test, right? So what is this? It's an obstructive lung disease. So what does a pulmonary function test show? The FEV1 by FVC, it will show you that it is less than 70%, right? And purely based on the FEV1 by FVC, purely based on FEV1 by FVC only, we classify the patients into mild, moderate, severe, and as well as respiratory arrest, right? So if you take in case of mild, okay, in case of mild, more or less the FEV1 will be normal, right? More or less the FEV1 will be normal. Whereas in moderate, the FEV1 is reduced to 40 to 69%. Whereas in severe, the FEV1 is reduced to less than 40%. Whereas in respiratory arrest, the FEV1 is reduced to less than 25%, right? And if you take the partial pressure of the oxygen, in mild, it will be normal. Whereas in moderate, it is more than or equal to 60 millimeters of mercury. Whereas in severe, it will be less than 60, right? In severe, it will be less than 60, right? And this is the point when the individual will develop possible cyanosis. This is the point when the individual will develop possible cyanosis. Okay. And even in case of respiratory arrest, the PaO2 will be less than 60, right? So this is about how to decide the severity, mild, moderate, severe, and as well as the respiratory arrest. So pulmonary function tests are the one which will diagnose your bronchial asthma. Next is your airway responsive test is for what? The airway responsive test is mainly to check if there is any allergic component in the development of the asthma, right? So this we call it as the atopic asthma, or this we call it as the extrinsic asthma, right? Atopic or allergic or the extrinsic asthma, all right? And this atopic or allergic or extrinsic asthma, this is more common in case of children rather than adults. This is more common in case of children rather than adults, right? So airway responsive test is number. And next is reversibility test that already I have discussed in the beginning itself. That reversibility test will help us to differentiate whether it is bronchial asthma or COPD. That is the purpose of doing the reversibility test, right? Now, coming to the treatment, I just tell you the Gina guidelines. So first and foremost, the important part of the treatment is what is your goal. See, whenever you're treating the patient with asthma, one important is you need to reduce the current clinical symptomatology. Whatever the current clinical features are there, reduce that. And next is you also need to prevent the exacerbation and you need to prevent the future attacks. And subsequently, you need to maintain the lung function. That should be your primary goal whenever you're treating a patient with the bronchial asthma, right? So you should be able to reduce the flare-ups and maintain the normal lung function. And for which, so for acute attack, we give bronchodilators, right? For acute attacks, we give bronchodilators, right? Whereas the leukotriene modifiers, leukotriene antagonists, that is montelukast and zefileucast, these are given for prophylaxis or chronic attacks, right? So these are given for the prophylaxis. Whereas bronchodilators and as well as corticosteroids, they can be given for the acute attack of the treatment, right? So this is about the goal and the medications. Now, before going on to the Gina guidelines, because in Gina guidelines, I'll be using the terminologies like intermittent, mild persistent, moderate persistent, severe persistent and all. What do you exactly mean by that? So, right, what is intermittent and what is the persistent form of asthma? So this is the classification given by the Gina guidelines. When do you call that the patient is having the intermittent attack? How many attacks should be there to call it as intermittent? It should be less than or equal to 2, right? It should be less than or equal to 2 days per week. The attack should be less than or equal to 2 days per week. And nighttime symptoms also less than or equal to 2 nights per month, right? Less than or equal to 2 nights per month. Okay. And what about the usage of the inhaler? Right? The number of times the individual has to use the inhaler is less than or equal to 2 times per week. Right? And there is no activity limitation. And the FEV1 is good in patients with the intermittent form of asthma. What about mild persistent? In case of mild persistent, the number of attacks will be more than or equal to 2 days per week and 3 to 4 nights per month. And there is requirement of rescue inhaler more than 2 times per week. And there is minor limitation of the activity. That is mild persistent. Then you take moderate persistent. In moderate persistent, these patients, they'll be having daily symptoms. Daily, right? And nighttime also more than 1 night per week. The number of attacks will be more than 1 night per week. And these patients with the moderate persistent, they will be daily requiring this short-acting beta agonist. And there is some limitation of the activity. And even if you take FEV1, it is reduced to 60 to 80%. Then when do you call it a severe persistent? Severe persistence is that the symptoms are present throughout the day, right? And every night the symptoms are there. And even rescue inhaler, if you take multiple times per day, the individual has to use this rescue inhaler. And there is extreme limitation of the activity of the individual. Okay. So this is about like the Gina guidelines of the assessment of the intermittent, mild, moderate, severe, persistent. Done. Now, saying this, let me now exactly discuss like what are the Gina guidelines. So according to the Gina guidelines, step 1, right? It is always step-up therapy. So step 1, that is mild intermittent asthma. So what do you mean by the word mild intermittent? What did I tell you? In case of mild intermittent, the number of attacks will be less than 2 days per week, or the number of attacks will be less than 2 nights per month. And the rescue inhaler requirement is less than 2 times per week. That is intermittent, and that too mild intermittent. So in mild intermittent, you need to give the low dose inhaled corticosteroids. Along with that, long-acting beta agonist, formoterol should be given. Okay, so this is like preferred controller therapy. Then what is the alternative controller? The alternative controller is instead of LABA, giving SABA, short-acting beta agonist. Right? And reliever therapy will be low-dose inhaled corticosteroids and as well as the formoterol. So controller therapy is what in case of step 1, long-acting beta agonist, formoterol, and then inhaled corticosteroids. Whereas mild persistent, Okay, so when did I use this word mild persistent? If the number of attacks are more than 2 per week, right? And if the number of attacks are 3 to 4 nights per month, and requirement of rescue inhaler is more than 2 times per week, and there is minor limitation of the physical activity, then we use this word called mild persistent, right? In case of mild persistent, these patients, the controller therapy will be daily low dose inhaled corticosteroids, right? Or as needed inhaled corticosteroids, right? Then the formoterol should be given. See, in case of step 1, as needed, it is not daily. Whereas in step 2, where there is mild persistent, you need to give daily. You need to give daily. Then what is alternative controller therapy? That is leukotriene receptor antagonist, that is montelukast or zeferlukast, or low dose inhaled corticosteroids with SABA. That will be alternative controller therapy. And reliever therapy will be as needed low dose inhaled corticosteroids, formoterol, or SABA will be given. So difference between step 1 and step 2 is what? Step 1, as needed, you are giving low dose inhaled corticosteroids, whereas in step 2, daily low dose inhaled corticosteroids is required. Then coming to step 3, which is like moderate persistent asthma. When do we call moderate? Daily, daytime, daily you will have symptoms. Nighttime, at least more than 1 night per week, you will have the symptomatology. And rescue therapy, SABA, every day you will be requiring rescue therapy in case of the moderate persistent. And your FEV1 is also dropped 60 to 80%, right? Now, so coming to the moderate persistent. So moderate persistent, low dose inhaled corticosteroids, then LABA. This will be preferred controller therapy, low dose ICS and LABA. Next, alternative will be requirement of medium dose or low dose inhaled corticosteroids with leukotriene receptor antagonists. Whereas in step 4, the dosage of the inhaled corticosteroids is increased. Medium dose inhaled corticosteroids along with LABA. Alternative will be high dose inhaled corticosteroids or add-on LAMA, long-acting muscarinic antagonist. Long-acting muscarinic antagonist, right? Okay, that will be your ipratropium bromide or tiotropium bromide. Then step 5 will be uncontrolled severe asthma. These patients will be requiring high dose inhaled corticosteroids, LABA, then biologicals, right? So these biologicals, like what we have is anti-IgE, anti-IL5, then anti-IL4, IL13. So these are the biologicals, right? And what is the alternative controller therapy? You need to add on LAMA and low dose oral corticosteroid therapy is required. And the reliever therapy will be as needed, low dose inhaled corticosteroid and formoterol is being given. That will be the reliever therapy. Okay, so this is about the Gina guidelines. But first, you need to know the steps, right? Mild intermittent, mild persistent, moderate persistent, then severe persistent, then uncontrolled. Then at the same time, you also need to know this table as well. When do you call intermittent? When do you call mild persistent, moderate persistent, and then severe persistent? When do you call this is what you need to know. So how do you do the prevention of these particular asthma? First and foremost, very important is avoidance of allergens. Then immunotherapy. Vaccination is required because the infection are the triggers for the acute attack. Vaccination is very, very important. Then the lifestyle changes, right? That lifestyle changes in the sense like where the individual should change the occupation, if at all, if the occupation is having exposure to dust, if the occupation is having exposure to the cold air. So lifestyle changes are very important, right? And the comorbidities in case of bronchial asthma includes like rhinosinusitis, GERD that will result in gastric variant of asthma, then obesity, sleep apnea, anxiety, or depression. So these are the comorbidities in patients with the asthma. Okay, so this finishes this very important topic, asthma. We'll discuss some questions, right? Mainly, I'll concentrate the questions according to the Gina guidelines treatment, because mainly over the treatment, the questions have been very frequently asked on the topic of the bronchial asthma, and that too on the recent Gina guidelines. Okay, right. So you see the first question. Right. So a 25-year-old patient with mild asthma experiences symptoms twice a month and occasional nighttime awakening. According to the latest Gina guidelines, what is the preferred controller treatment in this patient? What is the preferred controller treatment in this patient? So, what is he having? Mild asthma, symptoms twice a month, occasional night times awakening. What is required? So, this patient comes under which particular step? This patient comes under step 1 of the Gina guidelines, right? Step 1 of the Gina guidelines. Okay. So, according to this particular step 1, what is that we have discussed? These patients will be requiring low dose inhaled corticosteroids as needed with the formoterol, right? With formoterol. So, this is the treatment, right? Very good, Kesha Tendulkar. Yeah, Tandukar. Okay, according to the latest Gina guidelines, this patient, he comes under the mild intermittent asthma. So these patients will be requiring the low dose inhaled corticosteroids along with formoterol as needed. Done. Next, second question. Okay, so we have a 42-year-old patient with moderate persistent asthma, right? Moderate persistent asthma. And he's on low dose inhaled corticosteroids and LABA combination, but still has daily symptoms. What do you think is the next step in this patient? So, what is this patient having? This patient is having moderate persistent. Right. So, what do you understand by this word moderate persistent? Moderate persistent, yeah. So, moderate persistent means where the preferred controller therapy will be low dose inhaled corticosteroids and LABA combination. If at all, with low dose inhaled corticosteroids and LABA, if the patient is not responding, then you need to step up the therapy, right? Where you need to increase to medium dose inhaled corticosteroids plus LABA, right? So that will be the treatment in case of the moderate persistent. Moderate persistent. Okay. Next question. So we have a 55-year-old patient with severe eosinophilic asthma, remains uncontrolled despite high dose inhaled corticosteroids and LABA therapy. Right? Severe eosinophilic asthma remains uncontrolled with high dose inhaled corticosteroids and LABA therapy. Which additional treatment is recommended in this patient? Yeah. So what is the answer? Right. No, no, it is not omalizumab. It is benralizumab. It is benralizumab. So when do you give benralizumab? And why the answer is benralizumab? See, it is a severe eosinophilic asthma, right? So in severe eosinophilic asthma, the drug that you need to give is anti-interleukin 5 monoclonal antibody. And this anti-interleukin 5 monoclonal antibody is the benralizumab, right? Or the other examples of anti-interleukin 5 monoclonal antibodies are mepolizumab. The other examples are mepolizumab is one molecule, or resilzumab. Right? Or reslizumab. These are recommended, right? Whereas omalizumab, it is recommended in, right, or it is used for allergic, right? It is used for allergic IgE mediated asthma. Right? Allergic IgE mediated asthma. So for them, you need to give this omalizumab. All right. So the answer here is, in severe eosinophilic asthma, you need to give anti-interleukin 5 monoclonal antibody, that is benralizumab. Done. Next question. Okay. So we have a 30-year-old marathon runner with exercise-induced bronchoconstriction, reports symptoms despite the use of SABA before the exercise. What is the preferred long-term management in this individual? So he's already using SABA, right? But in spite of using SABA, still the individual is having the attack. In spite of using SABA, still the individual is having the attack. So what is the preferred long-term management in this patient? Right. Yeah, very good, Kesha Tandukar. So we need to use the inhaled corticosteroids and formoterol before the exercise. Okay. So what the recent Gina guidelines recommend is, the recent Gina guidelines recommend use inhaled corticosteroids and formoterol before the exercise instead of relying only on SABA to prevent the exacerbations. Right. And the other alternative is the montelukast. Yeah, the other alternative is montelukast, that is leukotriene receptor antagonist. So that is alternative, but this is less effective. But this is less effective. So that is the reason why, what is that we give? It is, we need to use the inhaled corticosteroids and the formoterol before the exercise. Done? Next question. Okay. So we have a 60-year-old with asthma and COPD. Overlap in, and the patient is on inhaled corticosteroids and LABA, but still has the symptoms. What is the recommended step in the management of this patient? Add LAMA, increase ICS dose, add oral corticosteroids, use an needed SABA, use as needed short-acting beta agonists. Yeah. So the patient is having, yes. So whenever there is an overlap of COPD, whenever there is overlap of COPD, you need to add the anticholinergic drugs, right? And this example here will be the ipratropium bromide, right? Ipratropium bromide or thiotropium bromide, right? Ipratropium or thiotropium bromide has to be given. Okay, so this is like if at all, if there is overlap of the COPD. Done. Next question. Okay, so we have a 35-year-old with intermittent asthma as well-controlled symptoms with as needed low-dose inhaled corticosteroid and formoterol. What is the next step in the long-term management of this patient? Mild intermittent asthma, well-controlled symptoms with as needed low-dose inhaled corticosteroid and formoterol. What is the next step in the long-term management? Yes. So, yeah, you need to continue as needed inhaled corticosteroid and as well as the formoterol. So what the recent guidelines recommend? Recent guidelines recommend as needed inhaled corticosteroid formoterol as a preferred controller for mild asthma. Right? Preferred controller for mild asthma. So it is effective in preventing the exacerbations, right? While reducing the corticosteroid exposure. Okay. So this will reduce the exacerbations. Right? So this will reduce the exacerbations. All right. So the answer is A here. Done. Next question. Okay. So patient with the severe asthma and the patient is on high dose inhaled corticosteroids and LABA and has frequent exacerbation where he is requiring oral corticosteroids. Which biological therapy is most appropriate for a patient with high serum IgE levels and the positive allergy test? Very good. So, like in those individuals with the high serum IgE levels and as well as the positive allergy test, the drug which is very important is the omalizumab, right? So omalizumab, it is an anti-IgE therapy. It is used for the allergic asthma, right? And those individuals in patients with elevated IgE levels, you require this omalizumab, right? Whereas mepolizumab, this is given for eosinophilic asthma, right? So this is given in case of the eosinophilic asthma. Okay, so the answer here is the omalizumab. Done. Next question. Okay, so we have a 50-year-old with severe asthma, and the patient is on high dose inhaled corticosteroids and LABA, and he present with chronic nasal polyps. What is the most appropriate biological therapy in this patient? Appropriate biological therapy in this patient. Yeah, very good. So the answer is the dupilumab. What is dupilumab? So dupilumab, this is an anti-interleukin 4 or interleukin 13, right? So anti-interleukin 4 or interleukin 13, that is recommended for severe asthma. That is recommended for severe asthma and nasal polyps, right? And this is also recommended for those individuals who are having a type 2 inflammation. The advantage of this dupilumab is it will reduce both. It will reduce asthma, and at the same time, this will also reduce the nasal symptoms as well. At the same time, it will also reduce the nasal symptoms as well, right? So that is the advantage of this dupilumab, right? Next. And omalizumab, just now I have said you in the previous question, this should be given in those individuals who are having high serum Ig levels, right? And a positive allergy test, right? Next. Okay, so a 19-year-old with asthma is using short-acting beta agonist more than 3 times a week, but refuses daily inhaled corticosteroid therapy. What alternative treatment can reduce the exacerbation risk? He is using SABA almost like 3 times a week, but refuses daily inhaled corticosteroid therapy. What alternative treatment can reduce the exacerbations in this patient? Yeah, so yes, anyone? Right. These patients, they will be requiring as needed inhaled corticosteroids and the formoterol. So this patient is requiring SABA almost 3 times a week, but refuses daily inhaled corticosteroid therapy. So to reduce that exacerbation, you require to give as needed inhaled corticosteroid therapy and as well as formoterol. That is part of the treatment that should be initiated even in case of mild intermittent asthma also, right? We don't directly start with the SABA. We directly start with LABA. That is long-acting beta agonist, right? Done. Next. Last question. So a 45-year-old patient with asthma and GERD has uncontrolled symptoms despite inhaled corticosteroids and LABA therapy. What is the next best step in the management of this patient? Start steroids, add LTRA, optimize GERD management, increase the inhaled corticosteroid dose. Yeah, very good, Nagaraj. So it is so this patient is like it is gastric variant asthma. So these patients, they will be requiring proton pump inhibitors rather than the bronchodilators. These patients will be requiring proton pump inhibitors rather than bronchodilators. So you need to optimize the GERD management in these patients with the bronchial asthma. Okay. So this is about the important topic that is the asthma. So mainly you need to be aware of this, the Gina guidelines, right? So you need to know when do you call it as the intermittent, mild persistent, moderate persistent, and severe persistent. This table is damn important. Then followed by that, like the step 1, step 2, step 3, step 4, and step 5. Mild intermittent, mild persistent, then moderate persistent, then severe persistent, then uncontrolled severe asthma, right? So this is about the today's topic, right? So tomorrow again at 6 p.m, like we will discuss few more topics for your upcoming exam, right? So thank you very much. See you tomorrow at 6 p.m. again.